Hello, everybody. Welcome to the urinary incontinence lecture. I think this is actually the shortest lecture I will ever give, so it's only a few slides. We've already talked about some of the pharmacology behind urinary incontinence treatment, but we'll just go through some drugs quick and how we use them. There is, of course, a lot more to GU than just urinary incontinence, and we talked about STDs quite a bit already during infectious disease, so I'm not going to rehash that now. And as far as prostate-related issues, those will be touched on during a specific men's health module in the spring during the endocrinology section. So really, this is all that's left. So this is urinary incontinence is quite a common condition, and most who end up seeking out treatment and taking medications don't really report adequate symptom relief. So the point in saying that is that the drugs we have right now don't work all that well. They can relieve some symptoms partially, but usually not completely. And things differ between men and women, but the treatment is generally the same for both genders. Our general causes: urinary incontinence, uninhibited bladder contraction, some sort of neuromuscular miscommunication is going on. Could be due to a number of different factors, and we'll touch on some of the treatments that would maybe address some of the common ones and maybe some of the less common ones. Stress incontinence would be just over time having poor urethral sphincter tone or function, which can happen as the body ages. It can happen if people are constantly holding their bladder excessively as well. An incomplete bladder emptying could be due to excessive pelvic floor muscle relaxation during sleep, potentially, and just, again, miscommunication between some sort of neuromuscular talking there. So initial treatments, weight loss can help with this. People who are heavier tend to have more problems with this. Dietary changes, reduction in consumption of alcohol, caffeine, and carbonated beverage. Not exactly sure what carbonated beverages have to do. They can be acidic, so maybe that has something to do with it. Normal fluid intake, again, watching fluid intake. If somebody is having difficulty or holding their bladder quite a bit and they're drinking tons of water on a regular basis, even, that could be problematic. So make sure that they're drinking enough fluid but not overdoing it. Constipation, if that's a problem, should be corrected, and we'll talk about constipation in detail next spring, so you guys can look forward to that lecture. Smoking cessation. This has been studied, but the questionable efficacy, whether it really has all that much effect on urinary incontinence or not. Probably not the biggest deal. Pelvic floor muscle exercises, also known as Kegels, can help strengthen those muscles and keep urine from, I guess, just keep the muscle tone in shape so that the bladder can hold its urine better. And then timed voiding and bladder training is something that you can consider. It sounds like something you'd have to do for a toddler, but it's more about just following your body's natural instincts. So we'll talk about constipation too. It's the same concept. When you have to go, you should go. If you're constantly holding your bladder, you can end up causing more issues, especially if you do it chronically over several years or several decades. So our first category of drugs, and the biggest category of drugs, are antimuscarinic medications. So these are a group of anticholinergic drugs, and they act as antispasmodics on smooth muscle in the bladder specifically. So there's a couple different options we're going to talk about, but basically they all decrease urinary bladder contraction, which will cause an increase in residual urine volume and decreased detrusor muscle pressure. The goal of therapy is to decrease the sense of urgency and frequency. And we talked about that treatments for urinary incontinence aren't great. Well, this is a great example where the studies have just shown that these have some modest benefit over placebo, but not a whole lot of benefit. And they rarely ever resolve all symptoms in patients. However, there are several agents approved. There's 6 of them. And usually you're going to switch between agents based on what kind of side effects the patient might be experiencing. So the 2 drugs on this slide are probably the 2 more common ones because they've been around for a while. They're generic, quite inexpensive. Oxybutynin or ditropan is the least selective of them. So as far as anticholinergic side effects, this one's going to have the most. So that's an important thing to remember about oxybutynin. It does come as a regular and extended release tablet, so you can take it. I think the regular release, you usually do it twice a day, sometimes 3 times a day. Extended release, you could just do once daily. Topical gel and a transdermal patch, I don't see these used all that often. Most people just take the oral form. And again, generic availability and quite inexpensive, which is why you see this medication used a lot. Yeah, it's not the most ideal one because it does have a higher incidence of those anticholinergic side effects like dry mouth, cause dizziness, sedation potentially. If a patient can't afford the other oral medications, but maybe their insurance will pay for oxybutynin patches, transdermal effects tend to limit some of the GI, dry mouth related side effects, so it tends to be a little bit better tolerated when we look at the anticholinergic effects as a whole. Tolterodine or Detrol it's kind of an older medication now, but it was one of the first medications to be more selective for specifically muscarinic receptors within the bladder. So think back to what we talked about several weeks ago when we talked about anticholinergic drugs in general. And there's a bunch of different muscarinic subtype receptors, and so there's lots of them throughout the body, and there's several that are specific to the bladder. In this case, we can tailor drug therapy to target those receptors specifically, and hopefully ignore other types of receptors that would cause side effects. So that's what tolterodine did, and it was one of the first drugs to come on the market. Detrol is really popular. Fortunately, these have gone generic, and both Detrol and Detrol long-acting have gone generic, so you can get a once-daily medication out of Detrol or tolterodine. So this is probably going to be the choice you're going to pick for most people because it should be relatively affordable, and it's going to be as effective as oxybutynin, and it's going to have a better side effect profile for most patients. Some other medications, so there's 4 other meds, and they're all antimuscarinic, they're all selective, and they're all brand name, so they're all expensive. The degree in which you're going to see these used is going to vary. I've seen all of these pop up on patients' med lists, so they are getting used in the community. Now, how do you get a patient to the point where they're on one of these? It's a great question, and I think it's a bit of trial and error, and it depends on how much side effects. So maybe you started with tolterodine, and the patient still had some systemic side effects, was having some anticholinergic problems, maybe getting confusion, something like that. Maybe they're really elderly and really sensitive to anticholinergic effects. Anyway, whatever the scenario is, you decide to stop that. And you don't want to give them oxybutynin because you know that that's less selective and that's probably going to have more problems. So you try one of these drugs, and maybe insurance pays for Vesicare, but it doesn't pay for any of the other ones. So that might direct your decision making there. Or you just pick one. Maybe you've had good luck with other patients in the past using Tovias, and so you try that. There's no real right option here. You can kind of pick and choose. There's no evidence that says, first of all, remember the evidence says that these drugs don't really work all that well to begin with. And furthermore, the evidence, there's no evidence to support that one of these medications is any better than the other one. All right, so generally what we're going to do is once we start somebody, you're going to look at 4 to 6 weeks for full effect, for efficacy. Once that period is done, probably not going to get a lot of benefit. You could increase the dose at that point, but after 12 weeks for sure, if you aren't seeing any effect, it's probably worth just stopping the medication altogether. And remember, the newer the agent, the more selective. Really, the only one that's non-selective, that's not as selective for the bladder specifically, is oxybutynin. So if you remember that, and remember that the rest of them are pretty selective, that's really all you need to take away from that. And then these drugs are kind of notorious for flagging as problematic for geriatrics. So you probably remember that I talked about anticholinergic drugs. Big deal for geriatric patient population. Elderly patients tend to be very susceptible to the side effects with anticholinergic medications. So how do we deal with that? Because these drugs are anticholinergic, and our primary patient population for urinary incontinence are the elderly. So it's a little bit of a catch-22 when we try and treat these patients. The rule of thumb is try something less selective, and usually the benefit that they're going to get, or try something more selective, usually the benefit that they're going to get from the drug, if they get a benefit, will outweigh the side effect risk. And most of these newer agents, if the patient can afford it and take them, especially tolterodine, which should be affordable for most people because it's generic, shouldn't have a lot of side effects. It's possible, but unlikely. So I think in general, you're going to see a risk-benefit scenario here where the side effect profile is tolerable enough where the patient, if they're getting benefit from the drug, it's worth it. And so that's where that comes down to. So you might see this pull up, and we'll talk about geriatrics and how we, there's some criteria for things like this, but at the end of the day, you might see this flag on something, when you order it that says, oh, this patient's 75, are you sure you want to order an anticholinergic medication? Like, yes, I want to try it. Just make sure you're telling your patient what they can expect as far as side effects go, so that they know, if they get too many of one side effect, if all of a sudden they're really constipated, or all of a sudden they're having such dry mouth that it's making them uncomfortable, or whatever it is, just make sure that they're aware of those series of effects that will get that are possible from taking any anticholinergic medication. There are a couple other options on the market that aren't cholinergic related. So one is called mirabegron or mirbetriq. It's a beta-3 agonist. Actually, there's beta receptors of the 3 subtype on the bladder. And what it does is, by agonizing those receptors, it helps to relax the smooth muscle in the bladder. You don't give this to patients with severe uncontrolled hypertension, because you do get some bleed over into other beta receptors too, and certainly we don't want to be having an agonist effect on beta-1 or mostly beta-1 receptors, right, for cardiac issues. So that would be a contraindication. However, otherwise, this is an okay medication to try. It's newer, I should say. And it's a bit expensive, so not a super common drug, but it is an alternative that's not anticholinergic. So let's say you've tried some of the newer antimuscarinic agents and patients still having issues, this could be a good alternative. Duloxetine or Cymbalta is a antidepressant in the class of serotonin norepinephrine reuptake inhibitors. And the only thing to know about this is that it's a stress incontinence, and it has some evidence that it works for this. You probably wouldn't use this unless you had a mental health related indication. It's also used a lot for neuropathic pain too. We're going to get to all this next semester, so don't worry about the details too much. But the point is, this is a different mechanism of action. It has some utility, and especially if you have some of these comorbidities like neuropathic pain or depression, it could be a good, useful agent for patients with stress incontinence too. And the last choice for people with a paralysis component, this is going to be somebody who's probably got spinal cord injury or some residual, well, there could be other issues too going on, but basically it's going to be somebody who, for some reason, these drugs just aren't going to work at all. There's no neuromuscular communication going on because of some sort of a deficit or injury. And botulinum toxin can be injected directly into the detrusor muscle, which paralyzes it. However, while this works quite well for urinary incontinence, there is a risk that you retain urine too much, and you can increase your patient's risk for UTI. And it's kind of like a risk-benefit scenario at that point. There'd be a lot of other factors you'd have to take into play, like are they catheterized? Are they, do they self-cath? How do they void normally? And that might lead you down a pathway to, is botulinum toxin okay for this patient? And then remember that they have to get botulinum toxin every about 6 months, sometimes more frequently, depending on how the patient's responding. Also, you have a cost issue substantially with botulinum toxin. It's expensive. It has to be done in an office by somebody very well trained to do it. So there's a lot of complications with that, but I did want to put it in there because it is an option for people who have like an absolute paralysis going on, or an absolute miscommunication going on that drugs really aren't going to do anything for. All right, so that's it. I'll get on to the renal topics now.